Hi there. Welcome to our session entitled Navigating Insurance, Medical Bills, and Medication Costs. Everything is negotiable. My name is Ansara Pabanga, and I live in Charleston, South Carolina, and I'm the mother of two daughters. My younger daughter had a combined kidney and liver transplant nearly 15 years ago this June. I've been a mentor to caregivers of children with chronic kidney disease for about 16 years now, and I recently joined the board of Transplant Families. I'm delighted to introduce our speaker today, Judy Maltz. She is the Vice President, Patient Advocate, and Board Member of the Transplant Community Alliance. Judy has been talking reimbursement since 1986 when she began her career in the home infusion therapy business. She calls it the original specialty pharmacy. After 10 years, Judy left the provider environment to work for healthcare delivery systems and the United Biosource Corporation. It was there that she found her true passion, the transplant community. In serving our community, Judy always takes a patient-centric approach, working to resolve immediate reimbursement issues through collaboration and communication with patients, families, providers, and payers. Judy has presented at over 100 transplant centers across the country and is a speaker at transplant patient support groups. She's currently an associate director at Exenda LLC and an active volunteer with her local chapters of the American Liver Foundation and the American Kidney Foundation. And she joined the Transplant Community Alliance Board in 2016. She's passionate about helping families navigate the many financial obstacles they face during the transplant journey. And she would like to share her years of experience with our transplant community. Without further ado, I would like to turn it over to Judy.
Good morning, good afternoon to some of you, and thank you very much to Transplant Families for inviting me to speak today. As Ansara said, I have a passion for what I do, and having worked in the transplant community for many years, even though that's not what I do during the day, my free time is spent working in that nonprofit world. So that's where I come to you as a member of Transplant Community Alliance here in Phoenix, Arizona. So we've got a pretty big presentation today. Let's get started. Can you see my screen, Ansara? I think we're sharing, so we're good. So we're going to be looking at navigating insurance and benefits, medical bills, and medication costs. Always our goal is to help the transplant patient and their family, caregivers, achieve a sustainable living situation that promotes transplant success through quality care, support, and adherence. So let's take a look at, first of all, benefit plans and eligibility. What is your child's benefit? Do you know what your benefit is, or what potentially you may be eligible for, your child may be eligible for? Any combination of these as well. There's a lot of benefit programs available to you at the federal level, at the state level, and of course, privately and through employer groups. Okay, so we're going to take a look at each one of these briefly. At the federal and state level, we have benefits. Medicare, you may know that or not know that dependent children are eligible for Medicare. And of course, that comes with, in certain situations. That's true for anyone. Medicare coverage is available for people, and there are many doors into Medicare. And so we have to look at the eligibility criteria to make that benefit determination. But Medicare may be an option. Medicaid also is at the state level, and that's a healthcare program for people who have, low income, limited resources. And in most states, children who receive supplemental security income or SSI payments automatically qualify for Medicaid. In some states, you might just, get into Medicaid when you apply and are eligible for SSI. Sometimes you have to sign up for it. So here already we're hitting a point of know what your requirements are in your state. Okay. There's also the child health or the Children's Health Insurance Program. And this is a program provided through the back in the 90s during the Clinton administration, where the CHIP program came into play. And this is really kind of a gap program, people who made too much for Medicaid income criteria, but not enough to pay for the very expensive and ever increasing premiums and costs for private insurance. Okay. And I want to tell everybody too that please, if you have a question, don't hesitate to ask during the presentation. I can stop and answer periodically. Okay. I'm happy to do that. So looking at that first program, can a child qualify for Medicare? And of course, again, it's about qualifying in certain situations, right? So if your child has end-stage renal disease, ESRD, requiring regular dialysis, or has already qualified for a transplant, a kidney transplant, and is on that list, then Medicare eligibility certainly is possible. And it's often just, you're immediately eligible. There isn't a 2-year waiting period. And typically, of course, it all depends upon the patient's, the child's parent, on how they get into Medicare, and that the appropriate work credits are in place, and that Medicare eligibility is even an option for the child. Okay. A child may also have a disability that does result in entitlement to Social Security disability insurance payments, or SSDI, right? So if your entitlement is based on disability, like everyone else for Medicare and disability, there is a 2-year waiting period before the Medicare benefit begins. It's important to know that the first year when we're dealing with a patient with eligibility, with disability qualification, they're probably going to be on a Medicaid program, okay? And that transplant, and then first year after okay. Looking at Medicaid and child health insurance program eligibility. For Medicaid, again, this is a state program. There's some federal assistance there too, but generally these are programs administered by each state. So that's where there's a lot of differences between the states, between the Medicaid programs. So the income guidelines will vary. Your income levels will vary by age. We can see in some states that a child can have an income as low as 141% of the federal poverty level, right, in the 0 to 1 age group, and then go all the way up to over 300% of federal poverty level in the age group of 6 to 18. All of these vary between states. And so it's important to understand that when you apply for Medicaid, it could be different. And if you move, or if you're thinking of moving to, there's different qualifications from one state to another. Even though you may be eligible on Medicaid on one state, you may not meet eligibility criteria if you move to another state. The Children's Health Insurance Program also enables states to provide that health insurance to children for working families. Again, it's for people who have income that's a little bit too high to qualify for Medicaid, and again, too low to afford that private insurance. Understand that not all states now offer the CHIP program. Some states have opted not to provide it, okay? But what is best for you to do is to check with your state Medicaid agency. You're going to go to your Department of Economic Security for additional information. This is the place where you're going to, your starting point in terms of, I have a child with a condition, a chronic condition, a disabling condition that I need benefits for. Okay. So what about those income benefits that I talked about? I said the words SSI and also Social Security disability insurance benefits, right? So these are two types of incomes that the state and federal government provide to you based on, again, your limited resources and income and qualifying disability. So there is a difference between, of course, the income versus the health benefit. And like I said before, in some states, if you have qualified for supplemental security income payments, you automatically qualify for your state Medicaid, and you get the health care benefits under the Medicaid program. Okay. Same thing with Social Security disability, your insurance benefits there. These payments are made to people who have gone through the Social Security disability process. They were deemed and determined disabled. They are able to receive income, and that also may qualify them for Medicare or Medicaid. Once again, go to your local Social Security office, Department of Economic Security, and they will be able to tell you more about that. There is also a very good resource at the transplantfamilies.org site that summarizes all of this for you if you want further information. So let's look at what's covered through commercial insurance, right? We looked at there's benefits and eligibility and what you have, but what is covered? Know that there are more protections now than ever in terms of continuity of insurance. And certainly the Patient Protection and Affordable Care Act that was implemented during the Obama administration makes things a little bit easier for us parents. I have two children and ages 20 and 22, and I just know that I got to keep working till they're 26 because the marketplace and group and individual plans are required now by law to cover adult children through December 31st of the year that they turn 26. And that really is a very nice benefit. A lot of our children are still in college. They're still in school or some sort of school, or even just getting into the workplace and getting into a company that offers decent benefits can be a challenge. Okay, so just know that this is a protection for we, the American people, that we have this, and we are protected. Okay. I want to stop here before we get into coverage and benefits and see if we have any questions. You can raise your hand or put it in the comments. Okay, we're going to continue on then. For coverage of benefits, we need to know, well, what's covered by insurance, right? And it's important for you to know what you have and what it covers. So if we have Medicare, we're looking at Medicare. Medicare is three parts. Part A is hospital, Part B is medical, and Part D is prescription drugs. The hospital benefit covers your inpatient charges. They also cover home health visits. So that's your skilled nursing. And laboratory services. I'm not going to get into how much Medicare pays because it really varies. And we can do that individually. If you want to get in touch with me and we can work through, what exactly your insurance covers. But in general, we have the hospital benefit covering inpatient services, home health, and laboratory. On the medical benefit, Part B, that's generally your outpatient services. So medical office visits, right? Procedures, radiology, x-rays, scans, MRIs, infusion therapies. Medicare has durable medical equipment also covered under there. A lot of times our infusion therapies are administered via an infusion pump. Many of you may be familiar with your child being on a feeding tube with a nightly, an infusion pump for the feeding tube. Also infusion therapies, IV therapies that need to be on an infusion pump. Sometimes Part B, we cover some oral medications as well. And there's a special category, actually, if your child is on Medicare, where Medicare does cover some of the oral immunosuppressants associated with the covered transplant. Medicaid and CHIP, all right, again, these are state programs. It covers all the above, same thing, hospital, medical, prescription drugs. But know that with Medicaid and CHIP, and with most payers, right, even Medicare, there are restrictions. Medicaid, though, is more restrictive with respect to its networks, right, and the drugs that they will put on their preferred drug list. It is all based on their contracts and rebates that they receive from the drug manufacturers where they place a particular drug. There are different rules that apply to the contracted providers in each state. I can tell you, for example, here in Arizona, with our program, we have Medicaid managed care. It's also called the Arizona Healthcare Cost Containment System, or ACCESS. And they have a preferred drug list, right? There are rebates that come from manufacturers. However, they also have a supplier manual that says very clearly that that PDL should be followed. And they want you to follow it as a provider. They want you to prescribe the drugs that they recommend and have put on there, again, for a good reason. They got a rebate from the manufacturer. But if the provider feels that it is in the best interest of the patient to do a drug, or to administer a drug, or to prescribe a product that is not on the preferred drug list, then they can do that and it can be approved. So right there we see, and that's something that I use all the time in my daily work out there working with physicians and other providers, that the physician, the prescriber, does have a lot of control and has a lot of say and can make an argument, can make the case for why he or she wants your child to be on a particular medication as opposed to another. All right. Just know too that hospitals participate in the state Medicaid programs. So hospital charges are covered. I'm going to just touch a bit because it's a federal program, but TRICARE, of course, is for your military families, dependents. Again, same thing, hospital, medical, and prescription drugs are all part of the TRICARE benefit. Again, with restrictions. TRICARE especially, a limited number of providers. Probably there will be, depending upon the presence, the military presence on bases within your community, you'll see, more or fewer providers, as the case may be. But again, the same thing. There's a network. For example, prescription drugs are covered through and must go through one particular specialty pharmacy and pharmacy benefit manager. Otherwise, it's just not a covered benefit to you. So now looking, and I'm hoping that this is probably the most common insurance that people have, your commercial insurance. And whether this is commercial insurance that is through a group, right, or an employer, large group or small group, through the marketplace, or something that you have purchased privately. Commercial private insurance is where you choose your benefit, right? And again, hospital, medical, and prescription coverage is part of that plan. You may have a type of plan, for example, an HMO, which is a health maintenance organization, a PPO, which is a participating provider organization, or an EPO, exclusive provider organization. These are, the networks. These are where the plan has contracted with specific providers. Within an HMO, typically you can't go outside of your network, that contracted network. But again, with an HMO, I'm not going to get into the history of this, but there's a reason for that. And it's based on covered lives and, how a provider in that network is reimbursed. In a PPO or EPO, for example, you may have a little bit more choice. For those of you who have a PPO, like I do, I have a PPO through Aetna Insurance, and I can go and see a provider in network, but I can also see a provider out of network. And if I choose to go to an out of network provider, and that's fine, I'll pay a little bit more. I have a higher deductible. I have a higher coinsurance, but the choice is still there for me. Okay. What's important though is this: providers, not always by their choice, will move in and out of contracts or networks, right? Sometimes they're kind of booted out by the plan. Sometimes it's just not working out for them and they do not want to be a participating provider with that insurance anymore. That could affect you. So you want to make sure that at the probably end of each year, as they're doing any contracting or into the beginning of each year, check that each of your child's providers remain in your plan network for that year. Okay. If there are any changes, you're going to want to know about those long before you have to come in and make an appointment, before your child is sick and needs to see someone and they turn out not to be in your network anymore. Then you're at the mercy of trying to get an appointment with maybe a new provider and someone that does not know you. Be aware too, with the hospital and medical benefits, you may find through a group coverage that you have an insurance plan that covers your hospital and medical benefits, right? For example, like Aetna. And you may also have a separate, what we call a carve-out benefit for the pharmacy benefit manager. So for example, you may have a CVS Caremark completely separate prescription drug card. CVS Caremark and Aetna are not one and the same. CVS Caremark may not care what Aetna does or doesn't do, or whether they approve something or not, or what their preferred drug list and what they want you to take or your child to take, what that effect will have on the patient being in the hospital or needing another physician visit. Okay. These are plans that just don't usually talk to each other. And so that's sometimes where you may need the advice, the assistance of a patient advocate to kind of bring those two entities together to say, look, this is a patient who was on a therapy. Maybe it got started in the hospital, right? Hospital medical benefit, and needs to continue at home and get the prescription drug through a specialty pharmacy. That's a different benefit right there. And one might be approved, the other might be denied. We got to bring those two things together to make sure that there is a cohesive continuity of care, definitely, and that our insurances are working together. Regardless of what you have, you need to know that all of these things are in play. Utilization review or pre-certification or prior authorization. It goes by different names. Usually pre-certification is reserved for maybe hospital procedures, right? More expensive procedures. Prior authorization for outpatient procedures, definitely for your medications, definitely for your equipment, any therapies that your child might be receiving. There may be prior authorization processes in place. These are forms of utilization review that an insurance company is going to do, and it's all based on medical necessity. They're trying to determine, is what you're asking for medically necessary? Does it fit within the guidelines of your plan? Okay. And the way that we do that is from the provider. Again, coverage being based on medical necessity, it's the provider who has the responsibility of establishing, demonstrating, and communicating to the payer that there's a medically necessary reason for that procedure, medication, treatment, visit, whatever it might be. And they're asking for the insurance to approve it, prior authorize it so that they will get paid. Okay, so that it'll be covered and they will be paid for their services. The better the letter of medical necessity or the prior authorization request, there's a lot of paperwork involved. Of course, the more likely the request will be approved. You, as the parent going to your providers and going into a provider that may or may not know you, maybe there's some history, maybe there's history of medications, that the patient has tried and failed, it's really important for you to keep good records and good history, so that when you go to a different provider, when you are called upon to provide a history, it's comprehensive. Because an insurance company, if you come to an insurance company with all of that, establishing medical necessity, again, the likelihood is very high that your request will be approved. As I said a couple slides back, if they can deny it, right? And so you always have the opportunity to appeal. And there's usually two levels of appeal at the provider level, okay? One type of appeal may be a peer-to-peer review, where you have a physician setting up an appointment with the insurance company and some clinician, whether that's a clinical pharmacist or another physician, medical director. That peer-to-peer often can get clinicians talking to each other, and generally usually are favorable to the patient's request or to the provider's request. Note too that on an appeal level, probably the third and final level is a grievance on behalf of the patient. But again, you are really relying on the provider to do the prior authorization and the appeal, because it's their service they are trying to get covered. Okay. Let's again take a minute here, and it looks like we've got some questions in the chat. So let's see. What is coinsurance and why do I have to pay it is one question. Good question. Coinsurance. So typically when you have insurance, you start with, especially with private commercial, you have a deductible, and that's something that you have to meet, pay out of pocket before anything is covered, right? We usually have it with our car insurance too. You pay your deductible. Once your deductible is paid, then you have either a co-insurance or co-payment. Co-insurance we usually reserve for, the hospital and medical coverage. And this is where your insurance is paying a certain percentage, usually somewhere between 70 and 90%, and then you pay the other percentage. Okay, so you may have a 30, 20, or 10% co-insurance. That starts tracking up to a certain maximum dollar amount that you pay out of pockets. It's called your maximum out of pocket per year. Once you hit that, then your insurance typically takes off and pays at 100%. Okay, so it's important for you to know, look at your benefit booklet that you receive, look at a benefit summary document that you can request from your employer to find out what your co-insurance is. Why do you have to pay it? Because it's insurance, because you do. Okay. Copays, on the other hand, we usually flat copays. Copays are what we kind of use the terminology. They're really the same thing, but it's kind of something we reserve for medications. So you have a copay when you go to the pharmacy. It's your share. It's your cost share of the benefit until you get to a place where your insurance says, okay, you've paid your max. Now we're going to take over and pay 100%. Okay, next question. My child's medication. Yeah.
Oh, I'm sorry.
Yeah,
I'm sorry about that, Judy. The next question is, my child's medication was denied by insurance, even though their doctor approved it. What can I do?
So, okay, so your doctor writes the prescription for the medication, and okay, that's what they do. But the doctor's office, the physician, the prescriber, is responsible for obtaining the prior authorization from your insurance company. So if it was denied, they're just denied payment. You can still, of course, get that medication, but you're going to pay for it. You're going to pay out of pocket for it. What needs to happen here is we need to look at the prior authorization and why was it denied. I find in all my years of doing this, and it's been a long time, that it can be anything. It could be something as simple as a diagnosis code wasn't entered properly, or maybe a diagnosis code isn't quite matching that drug code in the insurance company's system. So, something simple like that. Or it could just be that, they have a preferred formulary. Your child hasn't tried and failed the 2 medications that your insurance wants them to try. And so until they do, they're going to deny the non-preferred drug, or the one that your doctor's prescribed, the one that's maybe more expensive, or maybe not more expensive, but just the one that they don't have on their preferred formulary. So in this case, it's going to be an appeal. But the only way to start an appeal is to find out, well, what are we appealing for? Why? Why was it denied? Okay. Next question.
Great. So how do you know when a bill is negotiable and when it is not?
Oh, so that's a little bit challenging. As far as bills being negotiable, I have one slide that talks about the surprise bill act. I forget what it's called exactly. We'll get there. There are some bills that are negotiable because they are considered surprise bills. In other words, you had a procedure scheduled maybe at the hospital, and as it was scheduled, the providers that were brought in, assistant surgeon, anesthesiologist, were providers that were not in your health insurance network. And so now you're subject to this out-of-network expense that's higher than what you would normally pay. So there's protections there. In terms of a bill being negotiable, this is something that you need to work with the insurance, or not the insurance, but the provider. So large institutions, and you can work to negotiate your bill and work on a payment plan as well, but work to have that potentially reduced. It's really difficult to be able to just kind of say this bill is negotiable. The billed amount is the billed amount. What's important for people to do is to make sure that you are within network, right? That you know what services are being provided to you, and to, if you can, get an estimate of charges beforehand. Okay.
Great. We have a few more questions, but I don't want us to interrupt your presentation. So why don't you continue on, and we'll keep these questions in the queue. Okay.
Okay. Yeah, we'll address them. So again, and this is kind of following along the same theme here, right? Payer tactics. What's the deal? We've got insurance companies that are constantly trying to shift costs, and they have their preferred brands and generics for a reason, and it has to do with, of course, the costs to them, the costs, the contracts that they sign. Pushing market share for particular medications. When a drug is a preferred brand medication, that means that another medication likely out there is non-preferred. And that's just what your insurance company is doing all the time. When you go to the physician, when you go to your prescriber, they're prescribing what they feel is appropriate for you, for your child. They have, their preference in terms of medication, and it doesn't always align with the insurance company, right? Sometimes we have insurance companies also driving patients to their mail order program. A mail order program is fine if you are established probably on a maintenance medication and things really aren't changing. But when we have our transplant kids and our kiddos are, local, and even if it's in those first few months or years, things do change. You want to know who your pharmacist is. You want that specialty transplant pharmacist. You want to be able to reach your pharmacist on the phone, right? And so your preference may be to go to a local specialty pharmacy. Insurance companies want to keep pushing you to mail order because that's cheaper for them. Okay. The other thing too is, and we see these lately, they are limiting the use of manufacturers' copay card programs. And these are drug manufacturer copay card programs. There's a couple things here that we'll review: the copay accumulator and the maximizer programs, right? Little by little, though, we see that there's legislation being passed in various states, okay? So it's important, again, to know how, what is allowed in your state, what's not allowed. We talk about copay card programs and these copay accumulator programs. In Arizona, I know there was in 2019 or 2020, our legislature passed legislation that said that these copay accumulator programs could not be used for any state regulated insurance. Okay. At the time, I think there were 5 states in the nation that also had passed some legislation. The National Organization of Rare Disorders, right, NORD, drove the initiative there and presented to different states, and there was legislation pushed up in various states. I think now we have about 10 or 12 states that have legislation against this. All right, but it's slow coming, and it requires us, right, calling on our legislators to pass some of this, again, because it's about protecting the patients. So let's take a look too at some of these issues that we come across with various payers. So on the commercial or pharmacy benefit manager side with Medicare and if Medicare Part D, Medicaid and Medicare Part D, if you come across the issue of the drug that your doctor has prescribed as non-formulary, well, first of all, ask if you can have a formulary exception. All right. The worst they can say is no. Okay. If you can get it, request it, right? It is the right of every Medicare Part D beneficiary to request a formulary exception. Again, going back to my previous slide, it's all based on medical necessity. It's based on how strong that argument is from your prescriber as to why he or she wants your child on a particular medication as opposed to another. The stronger that argument, the more likely your request will be approved. And don't forget, employers are the ones that make the decisions and can make exceptions. It's not always easy for us to approach our employer, to have a relationship with that employer or HR department with respect to our child or our spouse's health coverage and issues. But if we are in a situation where this is just something that you must have, and you're working with your physician, and you are working to keep your child in good health, out of the hospital, not flaring, not having issues related to the medication that your insurance is saying you have to try just because we have it in black and white. Express that, tell that to your employer, ask for an exception. Okay. Same thing for a non-preferred brand, right? That's got a high copay or co-insurance because it's on a higher tier. Tier exception requests exist. Under Medicare Part D, again, it's the right of every beneficiary to request a tier exception. I'm not saying they're going to grant it, but you can request it. Okay. Same thing with commercial insurance. You can also obtain a manufacturer's copay card. And this is for commercial benefits only, not to be used with Medicare, Medicaid, or military. So that's TRICARE. And of course, there's also the charitable organizations for copay assistance that are out there, and we'll review some of those. Sometimes we have payers that are saying you're going to get a penalty or pay a penalty when you don't use the generic. Okay, so when there's a generic product out there, but your doctor is saying, I want you on the brand drug, you can ask for a generic penalty waiver. Again, the worst they can say is no, you need to request it and push for it. Okay. And lastly, the Medicaid maintenance medication program. So there's sometimes, and I've seen these, where once you have been started on a medication, and maybe you're getting that medication at a local pharmacy, right? The insurance has identified this as a maintenance medication, and they make a requirement that you have to get it from mail order. Okay. So those are programs also that may exist that you can see if you can opt out of. I'm going to go back a couple of slides. Remember here, New York passed the anti-mandatory mail order law, right? What this is doing to you for you is allowing you choice, right? So depending upon what state you're in, you're going to want to know if there are laws regarding the copay cards, the accumulators, these mandatory maintenance programs. All right. So briefly too, I want to discuss this because this is something that has become much more prevalent in more recent years. We went from about 40% of covered lives that were enrolled in an accumulator, a maximizer program back in 2018 and 19, and now it's about 79%. That's the latest that I read from end of 2021. That's a lot of covered lives of people that are enrolled in these programs, and they don't even know that they're enrolled in these programs. That's the problem with it. They sound good. They sound positive, right? An accumulator, a maximizer, like it's doing something good for you. But unfortunately, what they're doing is really the opposite. So an accumulator program, and let me tell you, United Healthcare is one of the first payers, large payers, that has implemented this. We see it all the time with United, Optum, RX. We're seeing it with Aetna and Cigna. They're all kind of coming around. But basically, insurance plans are using these accumulator programs as a way to, diminish that use of the manufacturer's copay cards. The insurance industry has never liked the copay card. They feel that it drives patients to brand drugs and costs more money because, of course, like I said in previous slides, they're pushing the generic. They want you to go to the generic. And with a copay card for the brand drug, that keeps you at that brand medication, which is costing them more. They can go ahead and have all the discounts and contracts that they want and get from the manufacturer. But you, the consumer, the patient, the families, they don't like it when we get savings. So here's what's going on. This accumulator, and we'll take a look at it in detail. But basically, they are not taking the copay card funds and applying those funds to your benefits anymore. They're not applying it to your deductible amount. They're not applying it to your out-of-pocket amount. They're just taking in the money. All right, and we'll go through an example real quick here. The other thing too is maximizer. Maximizer program is like the accumulator, but basically the insurance plan has they've taken the benefit and they spread it out across the year. You're usually looking at a copay, especially on a high dollar specialty medication of a few $1,000s with each fill. $2,000, $4,000, $6,000 per fill. They'll do that until they exhaust the copay card from the manufacturer. What the patient needs to do or what the family needs to do is understand, I'm enrolled in a maximizer program and I need to opt into a program so that your insurance will enroll you in their own program where the payer, again, they commit to a $0 or low out-of-pocket cost. We have a lot of manufacturers that have been tracking this. They've been on to it, and they have actually, they're addressing it in different ways. They are identifying these people up front when that first claim maybe comes through, and they identify the patient as being in an accumulator or a maximizer program, and they will basically cut off that copay card and enroll them in a separate program, right? Or just cut off the maximum annual amount of the card to that first fill. And that basically cuts it off at the knees. It makes the patient then go back to their insurance and say, my copay card's exhausted. Please enroll me in this, this maximizer program. where I have $0 out of pocket. But the problem is people don't know that they're enrolled in these programs. You have to ask. And so this is a good thing to ask probably every year at the beginning of the year, or if you're in a calendar year, but if you're in a plan year with your employer, usually April, maybe November, July, November, those dates, find out at the beginning of your plan year, or ask your HR department, have they enrolled your group in one of these programs? So I know this is a little bit confusing, but I want to give you an example. This is exactly what it looks like. So this is what your insurance looks like before an accumulator program is in place, right? So say, for example, you have a prescription that costs $1,500 a month, right? You have an insurance, or your deductible is $3,000 a year, and you pay 20% of the prescription cost after your deductible up to a maximum out of pocket of $6,000 a year. So in January, you fill your prescription, you go to the pharmacy, you present your copay card, they deduct the $1,500, it counts to your deductible. February, same thing, and here your $3,000 deductible is met. You've paid nothing, insurance has paid nothing, great. But the copay card money has gone to your deductible. As you start in with your next fill in March, April, and all the way through, your insurance is paying their 80%, that's $1,200, and $300 is your responsibility, but you're presenting your copay card, right? So they're taking that $300, and again, it's applying towards your out-of-pocket expense. So if you look at the bottom, you see that what the insurer has paid at the end of a year is $12,000, right? The copay card has taken care of you for this prescription, right? And taken care of the balance, which is $6,000. And you haven't had to pay anything. And that's, of course, the original intention and the benefit of these manufacturer copay cards, right? And yeah, it is an incentive to stay on their brand, right? But if your physician is prescribing that medication before you even knew about a copay card, your child's going to be on that medication, especially when it comes to transplant. We don't usually have a lot of choice here. It's not like we're being incentivized to go to that particular medication. It's what the doctor is ordering, right? So now let's look at this after the accumulator
Judy,
program is in place.
I'm sorry, Judy. Let me just interrupt for a second. We only have about 5 more minutes, and we've got quite a few questions. There are 2 questions that I want to make sure you have a chance to answer.
Absolutely.
The first one is, can I choose my transplant hospital even if I want to go to a hospital further away than the recommended closer one?
That's a question that I am not exactly sure of. I know that you can request and you can try to get listed at different transplant hospitals. It really does also depend upon what your insurance company will do. They have centers of excellence. They may be contracted with one transplant center over another. So I would say your insurance is going to dictate that first, and then you can go from there.
Okay, great. Okay. Thank you. This is such a wealth of knowledge that you are sharing. I think we could go on for hours. Here's another question. My hospital says we can't get a biopsy done without paying up front. That's thousands of dollars. What can we do?
Sure. So that to me is a question that says, I would ask first, is the hospital that you're going to get this procedure done in network with your insurance? If that is true, then they cannot ask for money up front. The only way that they can is if they have run your benefits and determined, maybe it's the beginning of the year, and you haven't met your $2,000 or $3,000 deductible yet. Absolutely. They can ask for that up front because they know that their benefit, maybe of the $3,000, the procedure is going to be allowed at $2,000. Well, that $2,000 is just going to be billed to you in the end. So they want to be able to get that up front. And yes, they are able to. They are allowed by insurance and, within state law. Okay. Another question?
Okay, great. Yes. Here's maybe our last question that we have time for. Okay. How do I prepare my teen transplant recipient to take care of all these bills by himself in the future? They seem so different, Medicaid and Medicare.
Okay. to take these.
So I think preparing your child who's becoming an adult at some point,
right.
What can we do to help prepare our children?
Absolutely. That's a really good question. And that's a tough one because, well, I mean, that's tough. Maybe I would say if it were me, I would be introducing my teen to the process slowly. What's incumbent upon you, the parents, are to make sure that you are keeping really good records. And I always appreciate and I always ask for when I work and consult at physicians' offices for timelines. When did things happen? What happened when? What was your insurance in at the time? Keeping a timeline kind of keeps it in, just I was able to make sense of things. As far as taking on bills, you want to be able to work with your, if you don't have group insurance, or if you're going to be moving into that situation of maybe disability, Medicaid and Medicare in years to come, you will be working with your state, DES Department of Economic Security, getting a case manager, knowing what to do at what time, what to prepare, and when to apply for benefits. Timing is critical on a lot of these things. Now, what I also want to share is that it's important for you to get a patient advocate. Okay. An advocate can help, again, just kind of hold your hand through that process, hold your child's hand through that process, somebody that's a go-to, that's an expert or has at least, access to resources that can help. We at Transplant Community Alliance I make myself available to you to get through this whole process. Okay. Because these are very challenging programs that we have. They are not easy to understand. I just kind of operate in this little silo, and I think everybody understands Medicare. You turn 65, you get Medicare. There's a lot to it. It's confusing. Don't feel like you're the only one that's confused, because, there's a lot of eligibility rules, and then there's exceptions to rules. The best thing you can do is have a patient advocate, have a case manager, people that know you and work with you and are aware of, your treatments, your therapies, and what's coming next. Okay.
Great. Thank you, Judy. This is so helpful. And we understand that if people have questions, they can contact you at info@transplantaz.org.
Yeah.
Wonderful. I'm sorry. We are to our time limit now. You have so much information to share. It's fantastic here. This is a great slide showing the resources that are available. And we cannot thank you enough for sharing everything you know. I learned a lot. And we really appreciate you being a presenter on this important topic. Really.
Thank you very much. All right.
Take care.